Right. Hello, everyone. Uh, let's discuss a coagulation question uh, as a part of mock exam for FRCPath Haematology. So the scenario was a 13-year-old patient with unknown severe hemophilia A presented to ED due to hematuria. The mother mentioned that she had given his last prophylaxis 16 hours ago. Examination shows that um, there is no bruising or bleeding at rest of the body. It's only hematuria that the patient has. Lab shows proton mean time of 12 seconds, APTT is slightly prolonged for 48 seconds, fibrinogen plus 5.1, white cell count 13, hemoglobin 145, platelet is 389. The question was interpret the above results, differential diagnosis, management, risk factors for inhibitor, and emicizumab discussion. So let's go to the candidate answer. The candidate mentioned that the patient has prolonged APTT and there is leukocytosis with normal hemoglobin, platelets, total mean time, and close fibrinogen. So the interpretation is okay. There is prolongation of APTT and high white cell count, suspicion of um, either an inhibitor in this patient or there is um, associated infection as well. You can add your impression uh, in the interpretation of the results, but if you just interpret them, mentioning every test, then that should be fine. Then the next question was, what are the differential diagnoses and the likely cause? So the candidate has mentioned that breakthrough bleeding as a result of an inadequate dose of prophylactic factor VIII, okay, development of inhibitor to prophylactic dose, okay, other cause of hematuria like infections, passing urine stone, and acute hemolysis. Right. So the differential diagnosis here are for the prolonged APTT and high white cell count. This patient had recent prophylaxis, but still he has bleeding. Bleeding can be due to either a bleeding condition or because of the infection. So we would say that the patient has a differential of either severe hemophilia A with development of inhibitor, or the patient has received less prophylaxis, which is under treatment, or the patient has developed any infection, urinary tract infection. In pediatric population, never forget about non-accidental injury and AI. The patient may have any anticoagulation exposure like heparin exposure. These patients have Portacats, um, and they use the staff use heparin to um, keep the Portacat patent. So maybe the patient has heparin exposure. That's why the APTT is prolonged. And very rarely, I would like to say HLH because if I'm expecting a if I'm suspecting infection in this patient, then I would keep HLH at the bottom because HLH has both CT prolonged and APTT prolonged as well. It has a DSC type of picture. So differential diagnosis is the severe hemophilia A with inhibitor, under treatment, infection, non-accidental injury, anticoagulation exposure, rarely HLH. Likely cause in this patient is severe hemophilia A with the development of inhibitor. Then the next question was, what is the management of this patient? This patient is bleeding. He has hematuria. So divide your question into multiple parts, like immediate treatment and then assessment, further assessment, you can say, and then follow up. So immediate treatment from this, I mean this patient is bleeding. So I need a quick focus history of the presentation and symptoms and examination of the child for any other site of bleeding and bruising. Then um, I have to arrange uh, bypassing agent for this patient to stop the bleeding, which is NO7, and NO7 is mostly available in all NHS uh, hospitals. Fever may take time, but factor 7 is very easily available in the hospital. Um, I would like to know this patient DDAVP response. It would have been done previously, and I would know the status whether he is responsive to DDAVP or not. If this was a mild hematuria, I would have given DDAVP to this patient, but if it is moderate to gross hematuria, then I would not try DDAVP because you can give only limited doses of DDAVP to a patient. And the judgment says that this patient would need something stronger than DDAVP to stop this bleeding. So either consider fever in this patient or no 7. Um, and secondly, because we are suspecting infection in this patient, so infection screen ultrasound scan of the renal tract should be ordered as well in this patient. So this was the immediate management of the patient to address the bleeding. Once you have done all this, like you have given factor 7 or uh, you have taken the bloods from the patient, then you can do the detailed discussion with the parents and with the patient. Like if you don't know about the previous history detail of the history of this patient, you can ask about previous history of bleeding in this patient or previous history of bleeding while on prophylaxis, the dose of prophylaxis, compliance, recent change in the dose, or any recent procedure, or any recent infection, because these are the things like surgery and infection where you have a risk of development of inhibit. And then you can do general examination of the patient and the systemic examination of the patient as well. Then investigations would include the routine investigation for the patient and the separate screen for this patient because we suspect that this patient may have hematuria because of the sepsis. Uh, Chromogenic factor 8 assay uh, and the Bethesda assay for factor 8 inhibitor as well. We have already mentioned the ultrasound renal tract. So these are the few investigations that we have to do in this patient. Then uh, further management. Once we have received the results of few of the investigations, we can explain to the patient and care the result of these investigations and the possible diagnosis. The possible diagnosis here is uh, severe hemophilia A with inhibitor. This may be a shock to the parents or patients, so we need to give them psychological support. We need to tell them the likely causes of development of inhibitor. We need to give them information regarding the management of hemophilia in patient with inhibitor. And because this patient now cannot use the factor 8 prophylaxis, factor 8 concentrate prophylaxis, we have to tell them other options of prophylaxis, which is emicizumab. And then the patient may want to know what to do if this patient bleed in the future, because we cannot give factor 8 concentrates. So what are the options? So we have to tell them how we can educate them how we treat patients if they bleed on emicizumab or if any patient who bleed while having inhibitor. After that, once the patient is stable and able to go home, then we can give a heading of follow-up. So we can say, make sure um, Make sure that the patient has bleeding disorder card, contact cards. Patient is registered with National Hemophilia Registry. Patient is also registered with Comprehensive Care Center. Ideally, this patient should be managed at Comprehensive Care Center or in conjunction with the Comprehensive Care Center. So this is severe hemophilia A. They are usually advised to come to the hemophilia center. And if they present to DGH hospital, then the doctor from the DGH hospital usually contact the consultant hemophilia in the tertiary hospital. Make sure patient has follow-up booked, and if um, previously genetic screening was not offered to the family members, then you can offer them as well. Um, Advise about contact sports because children are actively involved in the sports. So we can educate them to limit the sports which has a lot of contact, uh, risk of contact injuries here, so we can advise them about it. We can give them leaflets about hemophilia, and they should have HemoTrack app as well. And we should tell them about uh, prophylaxis for hemophilia in the future, which is ideally emicizumab in this patient. This candidate has mentioned that TXA cannot be given with hematuria. This is correct. And desmopressin cannot be given in children. This is also correct, but this is not less than 2 years. DDVP is usually not given in children less than 2 years of age because of the risk of onset of seizures. We suspect that this patient has developed inhibitor, so we will not give this patient factor 8 consent. Ideally, check inhibitor after third dose till reach 20th. So this patient has already developed inhibitor, so no need to check it like this. Offer imicizumab as a prophylaxis. This is correct. Psychological support to the patient and family. This is correct. Education is okay. Genetic therapy is long-term management. Yes, if it is available, and the patient is fit for gene therapy, we can discuss with them. Then the next question is, what are the risk factors for development of inhibitors? Factor 8 inhibitors. The candidate has divided the inhibitors into two. One is patient related, and the other one is treatment related. Patient related family history of inhibitor increase the risk of developing inhibitor. This is correct. If there is a family history of inhibitor, then the patient has also a risk of developing inhibitor. Um, Due to genetic reason, I would say, but the data is not very clear. Research is not very clear why this is so. Again, the same lies for HIV status. If the patient is HIV positive, he has a lower risk for the development of inhibitor. This is correct statement, but maybe HIV patient is immunocompromised. That's why the antibodies are less likely to develop against factor VIII. Ethnicity reason research has shown that African and Hispanic ethnicity have high risk of developing inhibitors. Very low age and high age are at high risk of developing inhibitors. Mutation, I think it is intron 22 mutation or large deletion or null mutation has high risk of developing inhibitors. These are a few patient-related factors like the family history, Afro-Hispanic ethnicity, young age, positive HIV, negative HIV status, and intron 22 mutation. They lead to development of inhibitors. Then treatment related. If you have intense exposure to factor VIII, then this is a risk for developing factor 8 inhibitor. Intense exposure means exposure more than 6 days. If a patient has any major bleed, so this patient would be admitted for many days and he would receive uh, uh, a lot of factor 8 concentrate depending upon the type of factor 8 concentrate. If it is a standard factor or um, extended half-life factor 8 concentrate. Then surgery or infection or acute inflammation, they are the risk factors for developing inhibitors as well. And delayed start of prophylaxis is also uh, a risk factor for the development of inhibitors. The candidate has mentioned type of product, plasma derived versus recombinant factor 8. The research has shows that both carry the same risk. None of them is superior to other. Um, but recombinant factor 8 has benefit over plasma derived because plasma derived can lead to um, reactions, antibody formation, risk of HIV, hepatitis B, hepatitis C transmission as well. Then the last section was that the family want to discuss emicizumab as an option of prophylaxis. What information you will give to this patient? So candidate has mentioned explain about the medication as a bispecific antibodies used to overcome the effect of factor 8 need to be given as injection subcutaneously as 3 loading doses initially, then will be introduced monthly. Explain about its benefit to overcome the frequency of prophylaxis and develop habit. Improve quality of life by decreasing risk of bleeding and time from school. The risk of breakthrough bleeding is same as prophylaxis, and the level cannot be moni- level cannot monitoring the level of drug irritation at the injection site can cause recurrence. Need using bovine thermogenic assay. So in the FRCPath exam, you can be given a question like about a new drug, and this patient is going to use any bispecific drug like emicizumab or glofitamab or epcoritamab or loncastuximab, etc. There are many. Or this patient is going for any procedure like plasma exchange, CAR T therapy, allogeneic stem cell transplant, and the question would ask you what information you would give to this patient about this procedure or medication. So be ready for such type of person. They have appeared previously and they can come again as well in the exam. So make a template for medication and procedure leaflet and then apply that leaflet on all medication and procedure. Like if you have a medication like emicizumab, you can first say what is this medication. Emicizumab is a bispecific antibody or a monoclonal antibody or protein. Then what is the indication of this medication or why I need this medication? So uh, the patient, any patient with severe hemophilia A with inhibitor or without inhibitor, they are deficient in factor 8. So this antibody, emicizumab, mimics the effect of factor 8 to activate factor 10. So that is why this patient needs this medication because we need something to activate factor 10. So we need a factor 8 mimicker because factor 8 does not, this patient does not have factor 8. So this is the indication of uh, this medication. Then next question with me. Um, How does this medication is given to the patient? So it is subcutaneous or under the skin. Because you are talking to a patient, use a language which the patient can understand. Then any precautions before medication? Um, Emicizumab uh, should not be given if with fever. So we have to make sure patient has not received any emicizumab recently, has not received any fever recently, because fever and emicizumab they interact and can lead to thrombotic microangiopathy. Then, how often I would use this medication? So you can say that the initial doses are uh, loading doses, they are high dose. Like I would say that the first four doses, they are weekly, and they are high dose, which is called the loading dose. So the loading dose of emicizumab is 3 milligram per kg. After that is a maintenance period from week 5, which is either 1.5 milligram per kg once weekly, or 3 milligram per kg fortnightly, or 6 milligram per kg every 4 weeks. So you can say this medication has a loading dose and a maintenance dose. Loading dose is every week, and then the maintenance dose is either once weekly, or every fortnight, or every uh, 4 months. Then uh, then you can add what to expect during medication. The patient can have common side effect, they can have serious side effects as well. Common side effects are same for everyone, like allergic reaction, anaphylaxis, uh, injection site, rash, itching, and a serious one if it is given in presence of fever, then the patient can get angiopathy, thrombotic angiopathy. Patient can also get myopathy or myalgia, body aches, along with this medication as well. The next heading will be monitoring, how to monitor this medication. Usually, these patients attend emicizumab clinic after every 6 months, and where we check the emicizumab level. The tertiary centers, they have specific emicizumab clinic called EMI clinic, and they have a leaflet regarding emicizumab, which shows what tests to do if a patient is on emicizumab. Then um, you can add, is there any alternative to this medication? There is no alternative to this medication, but we can use factor 8 prophylaxis in those patients who does not have inhibitor. Then you can say the duration of medication. This is lifelong. Then next heading can be specific situation, like pregnancy, breastfeeding, uh, surgeries, procedure, etc. So then you can say contact. You will have to contact the your consultant, who will make a plan for this medication use during these specific situation. Then um, the last thing is always consent for this, that the patient has to consent for this medication, and after that you can add contact, who to contact to take further information from the patient, which is the CNS contact number. So if you summarize these points, um, you have included everything basically. What is this medication, indication, um, mechanism of action, precaution, side effects, alternative, specific situations, consenting, CNS scan types. I think you have not missed anything. And if you open the leaflet of any patient, it is almost the same as I have mentioned to you. So this was a coagulation question. We discussing further. We will be discussing further such mock question in the future as well. Thank you very much.